Let's quickly review the management of immune checkpoint inhibitor related pneumonitis. Here we're talking about when you're treating with PD-1, PD-L1 inhibitors as monotherapy or in combination with anti-CTLA-4 inhibitors. Here, the first thing that we need to figure out is what type of pneumonitis we're dealing with. Grade 1 is asymptomatic pneumonitis. We essentially took a CT scan and we see some ground glass opacities that involve less than 25% of the lung parenchyma. The key factor here is that the patient is asymptomatic. So that's grade 1. Grade 2 is when we have symptoms, right, really regardless of the portion of the lung that is involved. But in general, we're going to see less than 50% of the lung parenchyma being involved. So once again, grade 2, the key here is that the patient is symptomatic. Grade 3, then we have severe symptoms, and in general, then we see that the ground glass opacities affect more than 50% of the lung parenchyma. And also the other thing that we see is maybe we're treating a grade 2 pneumonitis and the patient has not improved after 48 to 72 hours of steroid treatment. And finally, grade 4 is a life-threatening respiratory condition. Okay, so based on that, let's see the 3 steps of managing each grade of pneumonitis. In the grade 1, then we consider holding immunotherapy. We don't necessarily have to. We can continue the immunotherapy. And then we're going to reassess in 1 to 2 weeks. We consider taking or repeating a CT scan in 3 to 6 weeks to ensure resolution of the pulmonary toxicity. In grade 2, the important thing is that these patients are symptomatic, right? And in addition to having the findings on the CT scan for ground glass opacities. So in this case, we are going to hold immunotherapy and start an infections and pulmonary workup and treatment, depending on what we find. The important thing here is that in this case, we do want to start treatment with steroids, either oral prednisone or IV methylprednisolone at 1 to 2 milligrams per kilogram per day. And we're going to treat them until the symptoms have improved to grade 1 or less, right? That's about 3 to 7 days of steroid treatment that should do it. And then we're going to taper the steroids for 4 to 6 weeks. Finally, for grade 3 or 4, then we're going to permanently discontinue immunotherapy. These patients, we're never going to re-challenge them with immunotherapy, and we're going to manage them in the hospital. We're also going to do our infectious and pulmonary evaluation and management, and we're also going to include cardiac evaluation and evaluate them for immuno to see if they're immunocompromised. Also, the treatment involves the addition of methylprednisolone IV, 1 to 2 milligrams per kilogram per day. And we're also going to treat until symptoms improve to grade 1. And then we're going to do a slower taper, right? In here, we want to taper them for more than 6 weeks for the steroids. And if they don't improve within 48 to 72 hours of treatment with steroids, then we're going to consider IV infliximab, IVIG, or mycophenolate mofetil. Okay, so that's essentially kind of like what the management is going to be. And then just finally, the resumption of immunotherapy is only going to be considered if the patient had grade 1 or grade 2 pneumonitis. If the patient had grade 1 pneumonitis and for some reason we decided to stop the immunotherapy, then we can re-challenge them once we see radiographic evidence of improvement. If the patient had a grade 2 toxicity, then those patients are on steroids, and we're going to wait until the resolution of the pneumonitis to grade 1 or less, and that they're no longer taking steroids. Well, I hope that helps with remembering the management of pneumonitis in patients receiving immune checkpoint inhibitors. All of this is in the NCCN guidelines, so just please review the guidelines appropriately before making patient decisions. Okay, thank you so much, and see you in the next video.